Bismillahirrahmanirrahim. Our topic for today is anesthesia and pain relief. Now, anesthesia is defined as a state of temporary induced loss of sensation as well as awareness. It consists upon a triad. The first point of the triad is analgesia, which is pain relief. Paralysis, which is muscle relaxation. Amnesia is memory loss. Now, who wants to remember their painful procedure? And before giving any anesthetic to a patient, we need to have a proper anesthetic protocols. The first part of anesthetic protocol is pre-medication. Now, pre-medication was all of those drugs that are given to the patient in order to prevent any grievous outcome that may occur in the procedure. It is also used to prevent all those comorbid complications such as hypertension. Now, if a patient has increased blood pressure, there is an increased tendency to bleed out on table during the procedure. So, such condition can be prevented by giving the patient antihypertensives. Now, our next point is induction of anesthesia. Now, induction is the word, it defines itself. Induction is to induce. Now, there are various drugs who induce as well as maintain the anesthetic effect, which we'll study in the subsequent slides. Our next point is skeletal muscle relaxation. Now, no one can dissect through a rigid body, so skeletal muscle relaxants are needed to overcome such a problem. Analgesia is for pain relief, and other drugs such as antiemetics are used because a lot of anesthetics have nausea and vomiting-like symptoms to it. So this basically helps such effects. Now, the residual effect of any anesthetic is relieved by opioids and benzodiazepines, which are also sedative. Now, our last point is whenever we are recovering a patient, we need to reverse that muscle relaxant effect. So we use neuromuscular block. Now we move forward to anesthetic agents. Now, in broad categorization, it is divided into two parts: inhalational and intravenous. Inhalational are those drugs that you breathe in order to have a sedative like effect, but this is combined with intravenous drug to have its full effect. Inhalational is further divided into two types. One is the volatile liquids and the other is gas. Now, volatile liquid includes ether, halothane, enflurane, isoflurane, desflurane, and our most favorite one is sevoflurane. It is given to children and adults who have needle phobia. Gases include only nitric oxide. It helps to preserve the blood pressure as well as preserve respiratory reflex, an excellent analgesic. But the side effect of this drug is it causes delirium, and post-op side effects also include nausea, vomiting, greenhouse effect as it is dangerous for the environment, and it is mutagenic. Now we go towards the intravenous, but before studying that, we need to know that there are two types of intravenous drugs. The one that induce the sedation and others that are used to maintain that sedation. So some have a single function and some drugs have a dual function. Example of the inducing drug is propofol. It sedates a patient within 8 seconds and it is given in continuous infusion for smooth muscle induction. And this drug is quality is that it is hemodynamically stable. Our next drug is thiopentone. It is also used in induction as well as maintenance. Now, this helps to reduce the metabolic rate as well as intracranial pressure. Hence, it is used in brain surgery and also in hypertensive because it helps in decreasing the blood pressure. Now, our next drug is etomidate, which is steroid derivative. It has a brief duration of action and it is hemodynamically stable. But the dangerous effect of this drug is it decreases the adrenocortical area, by which it can also cause Addisonian crisis. Now, lastly, our slow-acting drugs include benzodiazepam, which is diazepam, dissociative anesthetics such as ketamine, opioids including fentanyl, remifentanil, and even alpha-adrenergic are used as sedatives and has an analgesic effect such as codeine, which is also used in cough medicine. Now we move towards various types of anesthesia. Now, broadly, it is categorized into two types: general anesthesia, which has a full body effect, and local anesthesia, which has a regional effect. This includes the IV block, which is known as Beer's block, topical anesthesia, plexus block, spinal block, epidural anesthesia. Now, we'll study each of them individually. Now we'll move to its first type, general anesthesia, but before starting that we need to know its pharmacology.
First is general anesthesia, which makes the whole body lose feeling, movement, and consciousness. Drugs that are used to induce this type of anesthesia are called general anesthetics. Anesthesia performed with general anesthetics occurs in 4 stages that were first introduced and described back in 1930s. These 4 stages remain essentially the same over time. However, updated delivery methods and modern anesthetics have improved the speed of onset, safety, and recovery. So the first stage is known as induction. It is simply a period during which the patient goes from state of consciousness to a state of unconsciousness. Next, we have the second stage, known as excitement. At this stage, depression of inhibitory neurons in the CNS leads to increased excitement, involuntary muscle movement, increased heart rate, blood pressure, and respiration. Next, we progress to the third stage, known as surgical anesthesia. At this stage, there is a gradual loss of muscle tone and reflexes. Patient is fully unconscious, unresponsive to surgery, and has regular breathing. This is the ideal stage for surgery, and careful monitoring is necessary to prevent further progression to stage 4, known as medullary paralysis or overdose. At this stage, respiratory and cardiovascular failure occurs, which lead to death if the patient cannot be revived quickly. Now, let's move on to discussing how general anesthetics work. So the mechanism of action of general anesthetics is not entirely clear. Although early theories focus on a single common path of action for all anesthetics, scopic level, the action of general anesthetics on thalamus and reticular activating system leads to reversible loss of consciousness. The action on the hippocampus, amygdala, and prefrontal cortex causes amnesia. And finally, the action on the spinal cord is responsible for immobility and analgesia. Now, at the molecular level, things get a little bit more complicated. So to make it simple, we can divide general anesthetics into 3 groups based on their relative abilities to produce unconsciousness, immobility, and analgesia. But before anesthetics, the first group consists of intravenous agents, etomidate, propofol, and barbiturates. These drugs are much more potent at producing unconsciousness rather than immobility or analgesia, and they are commonly used in the induction phase. Their effects appear to be mediated by a subset of gamma-aminobutyric acid type A receptors, GABA-A for short. So GABA-A receptors are located both postsynaptically and extrasynaptically on the majority of neurons in the central nervous system. They are composed of pentameric arrangements of subunits around a central ion channel pore. When endogenous GABA binds to this receptor, it causes a conformational change which opens central pore, allowing chloride ions to pass down electrochemical gradient. This in turn leads to stabilization or hyperpolarization of the resting potential, making it more difficult for excitatory neurotransmitters to depolarize the neuron and generate an action potential. So when etomidate, propofol, and barbiturates bind to specific sites on the GABA-A receptor, they prolong opening of the channel, suppress neuronal excitability, and thus promote unconsciousness. Now, when it comes to side effects, etomidate can cause adrenal suppression and transient skeletal muscle movements, including myoclonus. Propofol is known to cause respiratory depression and hypotension. Lastly, barbiturates can cause apnea, cough, bronchospasms. To the second group of general anesthetics, which consists of intravenous agent ketamine and inhalation agents nitrous oxide, xenon, and cyclopropane. In contrast to Group 1 and Group 3 agents, these drugs produce significant analgesia. However, their ability to produce unconsciousness and immobility is relatively weak. Because of that, these drugs are typically used in the maintenance phase of anesthesia. Unlike the drugs in Group 1, the Group 2 drugs have little to no effect on GABA-A receptors, and instead their effects appear to be mediated primarily by N-methyl D-aspartate receptors, NMDA for short. NMDA receptors are located in the spinal cord and are crucial in pain modulation and processing. When neurotransmitter glutamate binds to NMDA receptor, it causes inflow of extracellular calcium into the postsynaptic neuron, which then activates a series of signaling molecules, causing the pain signal to increase and fire more frequently. Now ketamine, nitrous oxide, xenon, and cyclopropane selectively inhibit NMDA receptors, which ultimately prevents or decreases neurotransmission of pain. Group 2 general anesthetics also affect members of the 2-pore domain potassium channel family, which regulate the resting membrane potential of neurons. Specifically, they promote the opening of these channels, leading to increased potassium efflux, producing a reduction in neuronal excitability that contributes to their sedative effects. Now when it comes to adverse effects, ketamine can cause hypertension, tachycardia, and hypersalivation, as well as emergence phenomena, ranging from vivid dreams to hallucinations and delirium that may continue for 24 hours after treatment. Next, nitrous oxide and cyclopropane are known to cause dizziness, nausea, and vomiting. Lastly, we have xenon, which has many characteristics of the ideal anesthetic and has virtually no significant side effects. Now let's move on to the third group of general anesthetics, which consists of halogenated volatile anesthetics: halothane, enflurane, isoflurane, sevoflurane, and desflurane. In contrast to Group 1 and 2 drugs, Group 3 drugs have more diverse mechanism of action and are more potent at producing immobility. Studies suggest that volatile anesthetics produce unconsciousness via different GABA-A receptor subunits than those targeted by the Group 1 drugs. Also, many 2-pore domain potassium channels that are activated by Group 3 anesthetics appear to highly affect immobility rather than anesthesia. Just like Group 2 drugs, volatile anesthetics also inhibit NMDA receptors. A wide variety of other ion channels are also sensitive to volatile anesthetics, including neuronal nicotinic acetylcholine receptors, serotonin type 3 receptors, sodium channels, mitochondrial ATP-sensitive potassium channels, and hyperpolarization-activated cyclic nucleotide-gated channels. Now, when it comes to side effects, all of the agents in this group produce a dose-dependent reduction in blood pressure and cardiac output. Additionally, halothane in particular may cause cardiac arrhythmias and hepatotoxicity, while sevoflurane may cause renal toxicity. Now, before we move on, there is one more agent that's worth mentioning here, which doesn't belong to any of the three groups that we discussed so far, and that is dexmedetomidine. Unlike the other commonly used general anesthetics, dexmedetomidine has a unique ability to produce sedation and analgesia without the risk of respiratory depression. These effects result from its binding to the presynaptic alpha-2 adrenergic receptors of the subtype 2A, which are located in the brain and spinal cord. The action on these receptors inhibits the release of norepinephrine, terminating the propagation of pain signals and inducing light sedation. When it comes to side effects of dexmedetomidine, the most common ones are bradycardia and hypotension, as well as transient hypertension due to weak peripheral alpha-1 receptor agonist activity. Now,
in general anesthesia, medications are given to patients to render them unconscious, and due to which they are unable to feel any pain during any surgical procedure. Now we'll go towards a demonstration. Now, what normally happens in the OT?
Let me show you the usual tools of engagement. Number 7.5 endotracheal tube, number 3 MAC blade, 90 millimeter OPA, some propofol, Zemuron. Over here, our IV starts up, but I already started the IV. Sorry guys, can't show you that today. Patient's ready to go to sleep. Here's the propofol lidocaine mixture. I'm going to give her enough to just drift her off. Here we go. You ready?
Yes.
Alright, take some nice big deep breaths for me. So she is asleep and the neuromuscular blocker's gone in. I'm putting in the 90 millimeter OPA. And let's bag her, see how she does here. Nice. So everybody asks about bagging and ventilating. Here's my secret. You got to get that C-form and rotate the neck. Look how this lines up nice and straight. And it's just really, really nice and easy. You get that? So we're ready to intubate. So out comes the airway. Sublux the corner of the jaw nicely. Drop the blade gently down the right gutter and pull towards the feet. You guys can see that airway. It's beautiful. That's where I gotta go. Okay, so I pulled the tube back to 22 cms at the lip and inflated the balloon. We're good. That's what I like. I don't often show you guys.
The basic principles of general anesthesia is shown to you by the 5 corners of a star. It provides analgesia, amnesia, loss of consciousness, weakening of the autonomic response, and one of its side effects is motion sickness. Now we'll again discuss the administration of general anesthesia stepwise, the first phase being induction. Induction is either by inhalational agents such as halothane or by IV agents such as thiopentone, ketamine, and propofol. Intubation is by suxamethonium, which is a muscle relaxant. We give it approximately 1.5 mg per kg per body weight in the laryngoscope. Maintenance is by induced sleep. We give halothane. To cause analgesic effect, we give the patient nitric oxide, and for muscle relaxation, we give atracurium. For monitoring, we need to monitor the blood pressure, the temperature, and the vascular by assessing the ECG and BP.
Tracheal tube where she's... Now positioning is very important. So the arms are no greater than 90 degrees on these arm boards, as you can see, and so we're just a few minutes after induction. Heart rate still a little high, but that's going to drop down as soon as I give her a little narcotic. Blood pressure is great. Gas flow is good.
Adequacy of ventilation is seen by pulse oximetry. The last step is recovery. First of all of the agents during given this procedure are stopped. Only oxygen is given. Muscle relaxation is terminated by neostigmine, and atropine is given to inhibit secretion as well as prevent gagging from their own saliva. And after that, intubatory tube is taken out. Now, how to ensure a better outcome of anesthesia is simply by monitoring and having trained anesthetic. Accurate monitoring of vitals like temperature, heart rate, blood pressure, ECG, and oxygen concentration and respiration is monitored by pulse oximetry. The facility should have an accurate team for which CPR should be done upon patient if the code blue is initiated. Now, anesthesia is a very risky process, so it itself have a lot of complications which can be either intubation related, respiratory related, and even drug related. The intubation related problems are failed intubation, accidental bronchial intubation, trauma to the lips, teeth, pharynx, aspiration of the gastric content which result in gastric aspiration pneumonia, blockage or kinking of the tube, and delayed tracheal stenosis. Now, delayed tracheal stenosis is by damaging of the trachea, due to which later, whenever healing occurs, there will be tracheal stenosis, which means narrowing of the tracheal lumen. Now, this respiratory problem includes atelectasis, pulmonary aspiration, laryngoscopy, post-op pneumonia, pneumothorax, and laryngeal spasm. Now, drugs-induced problems are halothane can cause decreased cardiac output, as well as it can cause liver toxicity, whereas suxamethonium can cause hyperkalemia, pyrexia, and even allergy, whereas isoflurane causes respiratory problems. The general complications that can occur from general anesthesia includes hypothermia, hypoxia, hypoventilation. Now, there are 3 H, 1 P, and MDF. So this can be used as a mnemonic. H3PMDF. P is for pulmonary embolism, myocardial infarction, diaphoresis, and fire and electrical hazards. Now, one of the serious complications of general anesthesia is the failure to breathe after general anesthesia has been. Now, this can be caused due to obstruction of the airway, central sedation, hypoxia, hypercarbia due to overventilation, persistent neuromuscular blockage, pneumothorax, and central failure leading to respiratory arrest. Now, we studied a lot of disadvantages. Now, we'll go towards the advantages. Now, the advantages are long time anesthesia. It is also an anxiolytic, decreased bronchial secretions, laparotomy is best done by this procedure, and children who have needle phobia.